Good morning, everyone. Today's topic for seminar is the most common topic for oral surgery, which is exodontia. According to Jeffrey Ho, the definition of exodontia is exodontia or the tooth extraction is defined as a painless removal of whole tooth or tooth root with minimal trauma to the investing tissue so that the wound heals uneventually and no post-operative prosthetic problem is created. Now let's come to the applied anatomy of the jaw or the face. Here is the upper third of the face. This is the middle third, and this is the lower third. Now the middle third comprises of the frontozygomatic sutures, the maxilla zygoma till the upper lip, and this is the lower part, which is comprised of the mandible and the lower part of the mandible. As you can see, the different anatomical structures here is supraorbital notch, frontozygomatic suture, optic canal in this area, superior orbital fissure, as you can see here. Inferior orbital fissure is present here, and this is the intraorbital foramen. And in the mandible, this is the mental foramen, which is the mental nerve comes out. Now comes to the maxilla. Maxilla is a thin cortex with more spongy bone. So you can see the maxilla on right and left. The maxilla contains the maxillary sinus. This is the nasal cavity or the nasal bone area, and this is the dental area which harbors the dentition. Mandible, on the contrast, the mandible is a thick cortex, less spongy bone, less blood supply as compared to the maxilla. Let's come to the indications of the tooth removal. Severe caries, pulpal necrosis, severe periodontal disease, orthodontic reasons, malpose teeth, fractured teeth, pre-prosthetic extractions. Other ones are teeth in fracture line, teeth associated with pathologies, teeth in the firing line of radiation, orthodontic considerations, and supernumerary teeth. These are the following indications for the tooth removal. Now let's see the contraindications of the tooth removal. No absolute contraindication. Unstable systemic disease, example, unstable endocrine, renal or cardiovascular conditions, which are unstable, pulmonary or hematological diseases. The extreme geriatric patients, local conditions, example, radiation therapy, vascular lesions, malignant tumors, and damage to the vital structures, or any kind of damage to the vital structures. Now let's start with the pre-surgical assessment in terms of exodentia. First, you should ask for any medical risk assessment, check the emotional condition, clinical evaluation, radiographic evaluation, overall difficulty, and surgical approach. Let's start with the clinical evaluation. Then this, you have to assess the condition of the tooth, the status of the supportive structure surrounding the tooth, the status of the tooth in the crown, and adjacent structures. Now understand the interpretation of the pre-operative radiographic requirement. This includes knowledge of the normal radiographic anatomy, assessment of the condition of the surrounding bone or the tissue or the structures, assessment of adjacent vital structures, assessment of condition of the adjacent teeth, and the assessment of tooth in question. The sequence includes, which follows are first administration of the local anesthesia. Now wait for the local anesthetic effect to appear. Now assess whether the patient is comfortable or having the proper effect of the local anesthesia. Visibility is very important. Lighting and retraction of the adjacent tissues is also very important. Okay, check for the suction, assess, and then the periosteal elevator, which reflects the papilla and the periodontal ligaments. Now use the elevator to luxate the tooth in terms of delivering the tooth out. Use the forceps to luxate to expand the socket. Rotate to sever the periodontal ligament. Traction to deliver the tooth. Squeeze the alveolus and suture the wound or alveoloplasty preparation. Post-operative instructions and the medications to be given to the patient after this, and the follow-up should be planned. Now comes to the methods. This is intra-alveolar, which is done by forceps of the elevator, or the transalveolar, which is a surgical extraction. Now see the indications of the intra-alveolar extractions. In this, if there's a loose teeth present, firm teeth with intact crown is there, teeth facilitating proper access to forceps and or the elevators. Indications for the transalveolar extraction includes root pieces, severely undermined crowns, fractured teeth, brittle teeth, which is RC treated, unfavorable root forms, dense bone, malpose teeth like crowding or incomplete eruption, and proximity with the vital structures. Now let's understand the fundamental requirements during the extraction. First is adequate access, which is very important. Good visualization of the field so that the proper care of the site to be done. Unimpeded pathway of delivery of the tooth. Control forces to retract the adjacent structures and remove the tooth. Now let's understand the position. Standing or sitting in front of or behind the patient, depending on which quadrant you're working. Patient almost supine, back 10° to the ground for the maxillary teeth. Patient almost supine or semi-sitting, back 20 to 30° to the ground. Be comfortable, keep the back straight, head not to be bent forward, blocking the light. Access. This is to be achieved by mouth probes like bite blocks, side action mouth probes, not usually required in awake patients, as you can ask them to open the mouth properly. Now, retraction can be done with the help of Bishop's, Austin, or Minnesota retractors. Wider tongue blades can be used. Gingival retraction can be done by using the number 15 blade with the Moon's probe. Liberal facilitates application of the elevator and forceps and prevents the laceration to the adjacent structures. Reflect the papilla and sever the periodontal ligament. As you can see, this is the Moon's probe in which is helpful in terms of retraction of the papilla and the periodontal ligament. This is how you place your Moon's probe along the tooth and in between the gingiva and the tooth margin, and reflect the papilla carefully, which is subperiosteal reflection, so that the forceps beak can be placed properly here. Dental elevators are used to luxate the tooth, deliver the tooth. Do not lean on adjacent teeth. An alveolar bone used as a fulcrum in which by the controlled and steady forces. This is the placement of the elevator in which the beak of the elevator is placed right in between the interdental space, and the rotation is done in such a manner that the tooth which is to be delivered out is pulled away, and the path of extraction is followed. Now the elevator bone fulcrum, this is how the tooth is removed from the socket. The types of forces used for the extraction. Selection of the extraction forceps. Choose handle for access, comfort, and leverage. Choose beaks for adaptation to tooth. Proper placement, in which apical setting, beak level parallel to the long axis of the tooth is done. Controlled and steady forces is applied. Hold at the end of the handle for greater lever advantage. More power and more feel. Feel what direction tooth wants to come out and go with it. Never apply cross mouth forceps. This is how the bone expansion takes place when you properly seat the tooth. You can very well see that this is how the bone is expanded and the tooth is moved freely inside the socket, and this is where the tooth is delivered out. The forceps beaks are used or been made in such a way that it creates a wedge between the tooth and the alveolar socket, and because of this wedging action, the tendency of tooth movement is very easy. Now the basic forceps movements comprises of apical pressure, buccal pressure, lingual or palatal pressure, rotatory movements in which in case of single rooted tooth, and traction in which you have to pull it out. Just follow these basic principles in the movement of the tooth. Basic forceps movements is more buccally and less lingually. Teeth with single conical root, above movements with rotational forces. Maxillary pinch grafts. So this is your index finger and this is your thumb. You have to do a pinch grasp holding around the soft tissue or the gingival margin so that the patient doesn't move and the alveolar socket integrity is maintained. For the mandibular, this is the sling grasp in which the thumb is placed in the lingual side and the remaining four fingers is used to support the mandible. The order of extraction. The hardest first, harder to freeze last to allow local anesthetic time to work. Maxilla before mandible, as freezes first. Blood from the socket does not drip into the mandible. Mandibular field. But down throat, same as blood from the mandibular socket. Basic law of gravity because. And the posterior before anterior. What to check during and after the extraction? These are the following points which you have to check, which is click sound, inspect root of completeness. If incomplete, resorption or fractured, root is present in the socket. Adherent granulation tissue if there is any kind of granulation present. Fragments of the callus enamel bone in the socket is if it's present, and the cortical plates if there is any sharp or fractured plate present. Policy for leaving the root fragments, which includes if this is a small root which is 5 mm in length, root fragment must not be superficial. Tooth involved must not be infected or have an apical lesion on the radiograph. If near vital structures which may be injured, if there is any vital structures which may be injured because of the extraction of the root, if has potential to be displaced into the sinus, inferior alveolar canal, or submandibular spaces, would require a destruction of the excess bone. These are the conditions in which you can leave the root fragment inside the socket. Now the procedure for the extraction. Inspect the socket for granulation tissue, any fractured cortical plate, sharp margins. Remove the bone, fractured bone, loose fragments of the bone. Curate granulation tissue if they present any. Smoothen the cortical plates. Compress the expanded wall sockets and apply the pressure pack. Now comes the composition of the pressure pack, which it basically comprises of the cotton wool rolled into gauze, loosely rolled and sterile. Are sutures always indicated? The answer is no. Healing is by secondary intention, help to stop bleeding, prevent food impaction, general distance takes place, loose approximating sutures are to be present. Now the instructions to the patient to be given after the procedure comprises of maintain the pressure pack for 30 to 60 minutes. They should not be spitting for next 24 hours. No vigorous gargling or smoking to be done. No hot fermentation to be taken or the hot consumption of the food to be taken. Patient should be kept on soft liquid and cold diet for 2 to 3 days. Warm saline gargles after 24 hours. Now comes the complicated exodontia. This comprises of the following contents of the seminar are complicating factors, technical implications, technical goals, achieving the technical goals, and technical considerations. Now, the complex extraction means those extractions not involving impaction that cannot be removed by a simple application of elevator and forceps. In Peterson, it says retrieval of a tooth root or the teeth that are likely to be fractured or some other reasons have to be obsolete for to extraction. Some other reasons have an obstacle to extraction. Complicating factors include the crown, root, bone, diminished axis, adjacent and non-adjacent teeth, adjacent vital structures, and prosthetic concerns. Now let's understand it one by one. Crown. The destruction of the crown, example, because of the caries, complex restoration, fixed prosthesis, prevent the application of the instruments and therefore application of the forces. In case of roots, all those that results in unfavorable path of removal or increased resistance, like multiple roots, bulbous roots, root canal treated teeth, hypercementosis, ankylosed teeth, divergent or dilacerated roots. Others are multiple roots, as you can see in the pictures, and the bulbous roots. These are the root canal treated teeth with a periapical infection. This makes the tooth very brittle. Hypercementosis, as you can observe in the bony area, makes it very difficult to extract. These are some of the radiographs of the ankylosed tooth. Divergent roots and dilacerated roots. As you can see the curvature of the root in this radiograph. Now on the bone, if it's the periodontically healthy or not, there's increased density of the bone is present or increased bulk is seen. Diminished axis is also very important to observe first. And this causes trismus, scleroderma because of the oral submucous fibrosis, interfere with the application of the instruments. Adjacent and adjacent teeth and non-adjacent teeth. Highly carious adjacent teeth, root canal on adjacent teeth, heavily restored adjacent teeth, periodontically involved adjacent teeth, and lone maxillary molar or canine. Now comes the malpose teeth. Teeth which are positioned out of arch. Correct application of forceps may not be possible. Purchase point for correct application of elevators may not be applicable. Transcellular extraction may be the only choice in these cases. Now, the proximity of the vital structures. These comprises of lingual nerve and inferior nerve bundle in the mandible and maxillary sinus in the case of maxillary. Now, the prosthetic concern to be observed is preservation of alveolar contour, preservation of the attached gingiva. Achieving technical goals. This is improved access in which flap and bone removal is done. Improved mechanical advantage, which bone removal, purchase point preparation is done. Reduce resistance. Removal of bone support and section teeth, in which odontectomy is done to reduce any kind of resistance present. And the correct path of removal. Remove bone and section the teeth. Now the technical considerations includes primarily flap design, after that flap reflection, bone removal, sectioning the teeth, and this is called as odontectomy of the teeth, tooth delivery, socket toileting, and proper wound closure. Now let's understand the flap design types, which includes different types of flaps. This is called as envelope flap, in which you do the crevicular incisions around and reflect the full thickness mucoperiosteal flap. And after the extraction, just place the flap back and do the suturing. This is three-cornered or triangular flap, in which the difference is you give the releasing incision at the arm. This is the four-cornered flap, which is also called as trapezoidal flap, in which you give the releasing incision on both the sides. Releasing incision on facial aspect of the crown doesn't heal properly due to the tension results in the vertical clefting of the bone or the vertical clefting of the bone. Incision that crosses gingival papilla damage the papilla unnecessarily and increase the chance of localized periodontal problems. As you can see in this picture, this is the wrong and this is the proper releasing incision. Access to the surgical site depends on the flap size. 3-cornered flap, one tooth posterior and one teeth anterior in this way. 4-cornered flap, one tooth on either side is sufficient. So that this is the tooth on either side and this is the working tooth. Now comes to the incision of the flap. Play a vital role in health of a flap and the post-op healing. Made over intact bone. 6 to 8 mm beyond the anticipated bony defect so that it lies on the sound bone. The firm pressure is applied. Periosteum is to be incised simultaneously. Single stroke without breaking continuity to avoid the ragged border, which is very important. Blade to be changed if more than one flap is to be raised, so that the proper conditioning of the blade is present. Now comes the flap reflection. The reflection of the flap begins at the papilla with a sharp end of the elevator. Then the broad end is used so that the tearing is avoided. It is inserted at the middle and the corner of the flap. Dissection done with the pushing stroke, posterior and apical, and easy and rapid atraumatic reflection of the mucoperiosteum flap is done. As you can see in the picture, this is how you do the reflection of the mucoperiosteal flap or start the reflection of the mucoperiosteal flap. Prevention of the flap necrosis, which is blood supply of the flap. Wider at the base than the apex. Releasing incision converge at free end. Length should not be more than the width. Like this. This should be wider so that the base is wider and proper blood supply is intact, not the narrower base. Base should not be excessively twisted, stretched, grasped with a sharp instrument that might damage the blood supply of the flap in the future. Prevention of the flap dehiscence. Approximate flap margin over sound, healthy bone, gentle handling of the tissues, tensionless suturing are the key important parameters. Dehiscence causes bone exposure, which causes severe pain, bone loss, and increased scarring. Following are the precautions to be observed. Avoid vital structures like mental nerve exposure, lingual nerve damage, or facial nerve artery damage, and greater palatine vessel opening. If anterior flap is raised, nasopalatine nerve and vessels can be easily incised at the level of foramen. Bleeding can be controlled easily by applying the pressure. Nerve can regenerate quickly. A temporary numbness does not bother the patient. Advantage of the long flaps. Adequate visualization, healing by first intention, rest on the sound bone, flap not to be overexerted in vertical direction to avoid any vital structures. Avoid buttonhole flaps. In chronic sinus cases, sometimes need to include sinus in the tissue flap to avoid any buttonhole of the flap. Third one is bone removal. Bone belong to the patient and tooth to the surgeon. This is the basic principle to be followed in terms of any extraction or transcellular procedures. The unnecessary bone removal to be avoided. Bone removal before the tooth delivery comprises removal of the buccal cortical plate, 1/3 of the retained bone surface to be exposed, to the root surface to be exposed, guttering of the buccal bone through a trough is created between the bone and the tooth on the buccal and the mesial or the distal aspect. Height of the alveolus can be maintained. Postage stamp method. In this, the buccal cortical bone, apical 1/3 of the root is exposed. As you can see in the picture, this is the buccal bone guttering done and the exposure of the root is seen. Use of couplant chisel or bone removal can be done under local anesthesia. Use of hand pressure for bone cutting. Use of chisel or mallet under general anesthesia, fracture cuts to remove the buccal bone. Two vertical cuts, one anterior and one posterior, and one horizontal cut containing both the vertical cuts. Bevel of the chisel to face bone, and that is to be cut. Faces mesially or distal, cut and vice versa, and occlusal for the horizontal cut. This is how you use the chisel mallet. The fourth one is tooth sectioning and or called as odontectomy. Se- Sectioning of the tooth from the root, separate cusp, separate roots, or a combination of all. Advantages: individual sectioning with different path of withdrawal can be removed easily. Splitting of the roots better with the burrs, and creation of the space by the burr. Now the tooth delivery. Atlas said, give me a lever and a secure fulcrum, and I'll move the world." It will be depend on configuration of the route and direction in which it must be removed for the delivery. These are the mesial and distal directions, and this is the vertical direction. Straight routes can be elevated from sidewise. This is how you apply the sidewise pressure and deliver the tooth out or the fractured root out. In curved root, elevator to be applied on the convex surface. So this is the convex surface. Here you are going to apply the elevator and move the, this will be the path of eruption. In multi-rooted teeth or tooth with roots curved in the same direction, elevator applied on the convex aspect of the whole tooth complex. Multi-rooted teeth with root having configured lines of withdrawal. 1. Divergent on recurved root pattern. Roots to be separated before application of the elevator to convex surface of the each. Occasionally, elevators can be applied to unfavorable surface in case of infected root, resilient bone, bone loss without fracture of root, or if space has been created between the two roots. Now, this is how you remove the different fracture of those roots. Convergent root, curved roots, or elevator is applied to the convex surface. So here you apply the elevator and take the roots out. Elevator should be applied with a modest and controlled forces to avoid any damage to the adjacent structures. Sometimes it is essential to make more secure place for application of elevators, done by the drilling notch inside of the root, which is more apical at its depth. This is how you create an application site, or the application site is created with the help of burr. The round burr is used at an angle of 45 degree to long edge of the root so that it engages the root properly and deliver the root out. Now comes to the technique of open extraction of single rooted. Provide adequate visualization and access raise a flap. Determine need of bone removal. Reset extraction forceps under direct visualization extraction and grasp a bit of buccal and lingual bone. Improve mechanical advantage, grasp tooth root, small amount of buccal and lingual bone is removed. Use straight elevators in a shoehorn pattern, forcing it down and periodontical ligament space with a widening motion to expand the PDL ligament space and allow the small straight elevator to enter as a wedge and displace the root occasionally, occlusally. Proceed with bone removal over area of tooth. Bone removal in mesio-distal direction, same as width of the tooth. In vertical direction, which is 1/3 the length of the root according to the pattern, and then extract the elevator. Then extract with elevator or forceps. And heavy elevator crank pick can be used in such cases. If still difficult to elevate, prepare a purchase point with the burr as discussed earlier at the most apical portion of the area of bone removal, and the notch is 3 mm in diameter and the depth to allow the insertion of the instrument and pull it out. Now the technique for open extraction and multi-rooted tooth in case of mandibular first molar. Technique number 1 is annular flap reflected first. Tooth is sectioned buccolingually. Mesial and distal halves are formed. The section tooth treated as two single root teeth, luxated with a straight elevator and extracted with universal forceps. Now you can see or imagine in the diagram. This is how you split the tooth in two halves and treat it as two individual tooth. Deliver the tooth with a forceps in the individual manner. If the roots are remaining, section the root, put the elevator in between, pull the root out step by step. Now the technique 2, it includes triangular flap reflection, sufficient buccal bone removed to expose the bifurcation, mesial root section with the burrs, and distal root along the crown is extracted, mesial root elevated with the cryos. Technique 3 is if crown lost previously, reflect the flap, remove the crestal bone, section the roots in two halves and extract it individually. Now, in case of maxillary molars with divergent roots, if the crown is intact, reflect the envelope flap first, remove the small amount of crestal bone, expose the furcation of the tooth, separate the mesobuccal and distobuccal roots from the rest of the teeth, extract the crown with palatal root and with the palatal root with bucco-occlusal pressure, and palatal root the crown are delivered along the long axis of the palatal root. So let's understand with this diagram. This is how you section the tooth. You deliver the tooth out with the help of palatal root. Now individually take the buccal and the palatal root, buccal and the distal and the mesial roots. Avoid palatal force to prevent palatal root fracture. Elevate the buccal root one by one using the straight or crier elevator. Crown is missing or fractured. Divide the three roots, extract them individually. First extract the buccal root, then extract the palatal root, and then the lastly distal. In case of fractured root fragments, critically important requirements are good light and good suction. Close technique involves no removal of the bone, no raising of the soft tissue flaps. Useful if fractured root fragment was well luxated and mobilized at the time of fracture. Root trips is mobile and lying all loosely in the socket and can be capped with the retrieved with the loss of technique. Close with the retrieve. Now use of endodontic reamers can be done to engage the root in case of root canal. If unsuccessful, use open technique. This is how the reamer file can be used. If only the roots is already luxated and the length of the root is not very much, you can engage the reamer into the root into the canal and then pull it out. Now comes to the open technique. Open technique, the tooth was not luxated before fracture, dilacerated or hypercementosed. Two main techniques. Number one is similar or single tooth root, and the second one is open window technique. Now in this, the soft tissue flap is reflected. Apex of the root fragment is located. Burr used to remove the bone overlying apex. Instrument inserted in bone window and tooth displaced out of socket. Now another one is root of edentulous jaws. Difficult to judge the position of the root, which is very obvious, or the main difficult point. Insert a short needle of anesthetized gingiva and take a radiograph just before the operation. Better to retrieve the root fragment through the outer aspect of the jaw rather than alveolar crest to preserve the alveolar height. This is very important point to be remembered. Now come to the policy of leaving the apical root fragment. Consider if the root retrieval is not possible by closed technique or the open technique will be atraumatic. Three conditions should be present for the root piece to be left behind. Number one, must be small, not more than 4 to 5 mm in length. Root fragment must be deeply embedded in the bone and should not be superficial. Tooth involved must not be infected and there must not be radiolucency around the tooth apex. Now the risk of surgery considered more than the benefit in one of the three conditions. First is on root removal, excessive destruction of the surrounding bone occurs. Second is if root retrieval endangers vital structures. Third is if attempt to retrieve root fragments may displace it into spaces or the maxillary sinus. Now comes to the protocol to be followed if root is left behind. Number one, inform patient, do the radiographic documentation of it, its presence and position of the patient's record. Fact that the patient was been informed must be also be documented. A regular recalls to be done. Contact surgeon in case of any problem, in case of pain, swelling, pus discharge, or sinus formation. Now, the bone removal after the tooth delivery is aimed at smoothing sharp bone margins, reduce size of clot by reducing size of the socket, recontour the residual ridge for the prosthetic rehabilitation in the future. The loose fragments of the bone should be removed. Bone fragments with compromised periosteal attachment should be removed. Loose fragments act as a foci of infection and as they will be undergo necrosis. Now the next point is socket toileting. Now the things to be remembered at socket toileting is removal of the tooth does not complete the procedure. Procedure of healing and pain after pain depends on the socket toileting. Irrigate with copious amount of normal saline in the socket and and the apical position of the flap where it joins the bone. Remove infected granulation tissue using a curette. Seventh is closure. In this is achieved by approximation of the flap margins. Accurate position of the flap, which is important for primary healing, and tensionless sutures are important. If flaps are snugly in position and bleeding is controlled, sutures are unnecessary. Function of sutures. Number one, it creates the caught wound margin. Hemostasis, oozing socket but not in case of profuse bleeding. Holding the soft flap through over the bone. Maintain the blood cloth within the socket. Use of gel foam and organized cellulose. Now let's come to the aftercare. The maintenance of the oral hygiene, especially at the site of sutures. Avoid accumulation of irritants like plaque and food debris, which lead to infection and breakdown of flap. Infection will seep into the depth of tissue by weak effect. Weak effect. The eighth point is suture removal. After the clean debris over the suture material, using hydrogen peroxide and chlorhexidine, suture is cut with a sharp pointed suture cutting scissors very close to the mucosal surface and then pulled out toward the incision line and not away from it. Now comes the complication of the exodontia. No surgical procedure is free of complications. Complications can be immediate. Number one, fracture of the tooth, root adjacent cortical plates, tuberosity, buccal bone. Second is luxation of the adjacent teeth. Third is dislocation of the mandible, displacement of the tooth or root in the sinus, sublingual or infratemporal spaces. Fifth is hemorrhage. Sixth is oroantral fistula and any injury to the nerves. As you can see, this is the fractured tuberosity with a tooth. This is the intact tooth with the complete tuberosity fractured. You can understand with the help of the diagram in this, the time of extraction, this the buccal and the palatal area, which is completely removed and the help of the bone. We try to achieve the closure by pulling the flap back and putting the sutures again. Dislocation of mandible. The possible causes unsupported mandible and wide opening during the extraction. Inability to close the mouth. Posterior gagging is present. Anterior open bite. Hollowness over the TMJ in case of unilateral deviation to the opposite side or the cross bite. The management includes reduction, analgesics or anti-inflammatory drugs, and the rest. Soft diet supporting during the wide opening and yawning. IM elastics can be placed, and the last one is definitive management. The surgical management comprises of creation of obstruction, which are Daughtry's procedures, overlay grafts, implantation of pins, capsule application, injection of sclerosing agents, removal of obstructions like eminectomy and condylar shape. Now the another complication is hemorrhage. This local causes can be trauma to the bone, soft tissue, blood vessels, granulation tissue, clot dislodgement, vascular lesions, and neoplasms. Systemic cause can be bleeding disorders, coagulopathies, uremia, anticoagulant therapy, antiplatelet drugs, liver disorders, others like leukemia and celi and hypertension. The management can be preventive by taking the history prior to the procedure, screening the investigation by potential bleeders. Local management for the hemorrhage can be done by physical methods. Number one, by pressure application, suture application, using the ligatures to arrest the bleed. Bone wax can be applied. Oxidized cellulose can be used, or Surgicel can be placed. Thermal management can be done by heat hot pack, cautery, cold ice packs, or electrocoagulation procedures. Local management includes chemical methods in which adrenaline packs can be used, thrombin gel forms, or empirical therapy can be applied. In case of systemic management, history to be taken first. Investigations like blood clotting, bleeding time, clotting time, PTINR, and LFT, KFT, RFT can be done before to the treatment. Hemorrhage management another include empirical like vitamin K and calcium gluconate, platelet concentrates can be given, factor 8 concentrates can be given, PRP and fresh frozen plasma and whole blood can be given to the patient to control the hemorrhage. Another complication is oroentral fistula. Oroentral communication or oroentral fistula are the two different entities. Oriental fistula causes the causes can be because of the dental extraction, fracture of the maxilla, ablative surgery procedures, malignancies, Wegener's granuloma, Hansen's disease, or Guma. So you can see the oroentral fistula in this. The root apices of the maxillary posterior teeth are closely related to the antral floor of the maxillary sinus. With increasing age and the nasal sinus slowly enlarges so that the tooth roots often appear in the two-dimensional radiograph view to be protruding into the antral cavity itself, as you can see in this. In elderly patient, the bone barrier between the tooth and the sinus is thin and very brittle. As the tooth is manipulated with the forceps, there is a risk that the bone in the antral floor, which may be adherent to the roots will fracture and removed with the tooth, so leaving the defect and creating a communication from the mouth to the antrum via socket. Now, the clinical features for this are nasal regurgitation. Number one, escape of air, frothing, loss of nasal resonance in voice, positive trans illumination is there, foul smell, nasal discharge is seen, and haziness on the radiograph X-ray like PNS is seen. This is the radiographic appearance in which the haziness is seen. This is the area where the complete haziness is seen because of the oriental fistula. Now the management include first aid, plastic closure, proper closure, plastic closure, and the Cladwell Loo operation. Now the closure includes the advancement and rotational combinations. The different type of closure flaps can be local advancement flaps, bibuccal advancement flap, palatal flaps, combination of buccal and palatal flaps, distal flap, bone grafts, alloplastic materials, and finally the prosthetic obturator. Technique for oriental communication closures. This can be divided into three headings. One is local, distant, and grafts. Now, number one is local flaps. which is buccal flap. This is the simple advancement flap in or known as Berger's flap. In this, the advancement flap can be Raymond's flap, sliding flap is Moxar, and transversal flap is Schudoart's. As you can see in the picture, this is the oriental communication. You have given the releasing incision on the buccal side. The buccal full thickness flap is elevated, and the complete flap is taken on the other side of the palate, and the oriental communication is closed. This is the another flap. It's described and buccal sliding trapezoidal flap procedure for closure of the alveolar fistula. This is the trapezoidal flap reflection. Wu pointed out that the change in the vestibular sulcus is negligible by shifting the flap one tooth distally. The disadvantage is necessitates the greater amount of dentogingival detachment in order to facilitate the shift. Now, the Rehrmann's flap or the buccal flap, common buccal flap procedures of the closure of the minor alveolar fistula is used. Has a broad base that ensures adequate blood supply of the flap. This is the broad base. The flap mobility is improved by making parallel incisions in the periosteum at the base of the flap. Now, Schwartz flap procedures. In this, the mucoperiosteum overlying and the edentulous ridge in the vicinity of the fistula has been utilized in the form of transversal flap. You can see this. Buccal vestibular height was not affected following the closure. Does not offer greater mobility, and results in a raw area over the donor side. Now the palatal flaps. As you can see in the diagrams, the straight advancement flap or the palatal rotational advancement flap does not offer mobility for the lateral coverage suitable for closure of minor palatal or alveolar defect. The palatal rotational advancement flap provides adequate mobility and the tissue bulk to the flap. Now comes the regional flaps, which comprise of the buccal fat pad, tongue flap, distant, also known as distant flaps, like temporalis muscle flaps. Distant flap procedures. The larger fistula are technically difficult to close by local flaps in view to the limited tissue bulk. Number one is tongue flap. The anterior base partial thickness dorsal flap tongue flap is used, and the posteriorly placed full thickness lateral tongue flap is used. As you can see in the picture, this is the posterior based and this is the anterior base and this is the posterior base. This is how you take the flap and suture it on the defect side, and this needs to be sectioned after the period of 21 days. Now the adjuvant procedures include nasal enterostomy, sinus rigging, Cadwell loop operation, in which the degenerative changes and polyps on mucosis is removed. Delayed complications of the exodontia includes infection, dry socket, and osteomyelitis. Now, number one is dry socket, also called as alveolar osteitis. The possible causes of dry socket are excessive trauma to the bone, use of vasoconstrictors, menses or oral contraceptives, infection like different kind of infections if present. Now, this is the Burns hypothesis, which you understand, leading to the dry socket formation. After the extraction, during the trauma, the inflammation of the bone occurs, which causes the release of the tissue activators, and the plasmin is formed. This lyses of the fibrin and formation of the kinase and cause destruction of the blood clot, leading to the dry socket. This is the clinical picture of any dry socket. Now, the clinical features include manifest in 2 to 3 days after the extraction. The severe pain is present, socket devoid of any clot, necrotic tissue at the base, halitosis is present, and minimal inflation is seen. Management includes antibiotic therapy, analgesics, local treatment like gentle saline irrigation, obtudent dressings, and pom-pom dressings. Curettage at this point is questionable. Now, the infection can cause cellulitis, local gingival abscess, alveolar otitis, and extension in the adjoining tissue planes. Osteomyelitis is another complication which causes acute supinative osteomyelitis, acute infection, Predisposing factors for this osteomyelitis can be diabetes and immunosuppression therapies. These are the radiographic pictures showing the osteomyelitis. This. So these are the possible complications of the exodontia. This leads to the end of exodontia and the understanding of right from the first step to the last step and the things to be monitored in the patient care for exodontia. Thank you.